Sister Maggie, are you there? Never mind, Jonathan. I think we can commence the sessions now. And yeah, first and foremost, thanks for these collaborations, Jonathan and Daniel, right, your partners. And we are very privileged to have Emilio. Good to see you again.
Same here. Thank you.
What time is your time over the other side? Early in the morning?
It's 9 a.m. It's 9 a.m.
So we're about to end our shift. Thanks for having us.
Yeah,
And thanks.
I just started.
your day just begins.
Yeah.
And we're about to end. Thanks, Emilio, once again to have this partnership. Indeed, we are very privileged to have you once again to have this journey. And I think without further ado, we can commence the sessions.
Yep. Thank you very much. Thanks for your kind invitation. And we will start off with a couple of things that if there's any technical problems, please let us know through chat. My friends will be able to assist you. We will answer any question. If you have any question, please don't hesitate to just jump in and ask. But at the middle and at the end, we will have dedicated Q&A sessions. We will also have some polls. It would be nice if you can participate to see how we can react to what we are saying. Yeah. So we will start off today with a short introduction, and then we will talk about evidence-based practice, which is the basis not just of wound care, but everything in medical and health. So if we're looking at tissue viability, it's a fairly recent thing that has been added, because before the 1980s, wound care wasn't specialized. Although if you look actually into the history of wound care, it's very, very old. It started off almost 4,000 years ago. There's a clay tablet from Mesopotamia talking about what we are still talking about today. But we will obviously look more into the modern aspects of wound care, understanding, for example, what is the difference between tissue viability, wound care, and wound management. It's basically the same. However, we use the terminology of tissue viability because we are not just managing a wound, we are not just caring for a wound, but obviously we are caring for the patient as a whole. So yes, we are talking about the management of the patient. We are talking about the management of comorbidities, etc. But once you're in tissue viability, you want to understand that you are dealing with the patient, you are dealing with the family, you are dealing with the facility, sometimes even dealing up to governments. So the roles and responsibilities are really, really broad. So first and foremost, obviously looking at the appropriate environment for healing. And we will talk a lot about this in the coming modules, how we can create the environment of healing. But the most important thing to remember, it is not just putting a dressing. It's looking at the broader picture, understanding all the problems, all the issues that are there for the patients. So if to have to look like what can we do to make things better, and this is from a publication from a few years back, where they were looking at what they thought were the main problems in tissue viability. So the first one that they looked at was suboptimal practice. Are we doing the care according to what is really needed? They are talking about concordance. They are talking about patients not following orders. And they are also talking about product-related limitations. For me, this shows a problem of lack of education. Do we know how to use the dressing? Do you know exactly when and where to use these types of dressings? And we will obviously talk about that quite a bit as we go along. The other thing is insufficient patient engagement. Are we empowering and including our patients enough? So it's not the patient's problems, it's usually our own problem. So even understanding the wound is understanding the patient and understanding what is happening with our patients, because sometimes we just see the patient for 10, 20 minutes mostly, but the patient is living with that wound all the day, all the night. It changes everything in his or her life. Eating, sleeping, and social aspects of his life will be totally disrupted. So also understanding what is happening in facilities. And one of the big and huge issues that we are seeing more and more is the gaps on communication between ourselves. How do we communicate care between the different facilities, between the hospital, the primary care, community care, between the different specialists in the whole healthcare system? Understanding that communication is very, very important, because if we want to do proper engagement in wound care, one of the most important things is continuity of care. If we have a patient that has been discharged from the hospital with a specific regime and there is no communication, there will be total disruption in their care. We need to make sure that we are having a proper open multidisciplinary team care plan and communication, understanding about the diagnosis, understanding about what are the aspects that are related to the patients themselves, understanding about the plan of care that we need to involve the patients in it to make sure that they are empowered enough to be able to take care of themselves once they are discharged from our tertiary settings. So if you have to think about barriers to wound healing, the first thing that you would probably think about is the clinical aspects. Thinking about, is there enough blood going to the wound? Is there an infection? Is there a biofilm, exudate, etc.? But other things that we might sometimes forget about is the psychosocial aspects of our patients, how that wound is affecting the patients. Are they motivated enough to take care of themselves? The other aspect is the education or the lack thereof. People still using traditional logic and ritualistic practice is a huge, big issue that we find. And we will see today that with evidence-based practices, it is really important to understand what is new out there, how we can use it, how it can impact our patients' healing. Understanding that research is not just there to publish journals, to publish articles, but it is there to help us and remove these negative attitudes that we have sometimes to evidence-based practice, like trying to understand what is the best methodology of managing our wounds and our patients. The other important aspect that we have to look at is the issues with the profession itself, the lack of consensus, the lack of acceptability of guidelines and practices, the interprofessional rivalry between the nurse, the doctor, the physiotherapist, the podiatrist, etc. So how we will be able to breach that is by understanding the importance of evidence-based practice. However, going back quickly to what we talked about our patients, we used to talk mainly about compliance. Are the patients compliant? Are they obeying our commands? This is totally outdated. We don't just tell people what to do. And that is why we went on to concordance, which is basically a form of agreement that we reach with the patient and his carers about the treatment plan. But this has even changed more, especially during the COVID times and continued now, is empowerment of the patient, empowerment of the carer to take control of their own care as well. So what are our goals? Our goals obviously is to reduce healing time, understanding that whatever plan of care we have put in place, that we will see that it can reduce the healing time. And we'll talk a lot about that both today and again in other modules when we talk about standard of care. Obviously, the times of changing dressings every day has gone, although there are still cases that we do change the dressing daily, but we try to prevent that, because then we are also preventing wound complications, preventing also stress for the patient. And what we'll see when we especially go through the assessment part of the modules, which will be in a couple of sessions, How do we take care of our patients? First, understanding the disease process. What type of wound do we have? What is the history of the wound? What are those barriers that we already talked about? What is the status of the wound at the moment? And what are we going to do by managing a treatment pathway with our patients? So we start talking about evidence-based practice, which is the module for today. And the first question that we have is, I'm going to ask a question. I don't need an answer. Just think about it between you and yourself. The last time you did that dressing, why did you choose that type of dressing? Why did you choose that type of standard of care? Is it because maybe we have been doing this for many years and we think it works? Or is it because it was an order by a consultant and we believe that he is right and we will do it? Maybe it's because that's the only thing we have available. And one of the biggest problems is that there are so many options out there. How do we decide which dressing is the best for our patient? What we talk about choosing the right dressing at the right time for the wound at hand.
The gang is coming for dinner, and you are the designated chef. This particular gang is multi-generational, and tastes and preferences are, of course, all over the map. Vegans, vegetarians, carnivores, omnivores, gourmands, and gourmets. You pull out a favorite cookbook or two. You've customized your recipes to really fit the palates of the individual guests. You've remembered who's allergic to what. You've chopped and mixed and sautéed and grilled and sauced, organizing the cooking process so that everything will be ready, piping hot, at the table, on time. Of course, it's a hit. What does this little story have to do with evidence-informed practice? Plenty. Your ability to design and create a meal that is an out-of-the-park home run depends on your ability to synthesize evidence, harness your own practitioner wisdom and experience, and build the needs and preferences of your guests into an evidence-informed culinary delight. At its simplest, evidence-informed practice is a service approach that's based on these things. Research evidence, the stuff you find in journals, textbooks, and all the halls of academia, derived from sound scientific methodology, evidence that is valid and tested and can be used in the real world of your practice. Practitioner wisdom and experience, drawing upon your clinical excellence as you determine the best approach in a given situation. And the needs and preferences of clients, based on documented feedback from children, youth, and families that are fully engaged in the treatment process. This isn't about only doing things one way. It's about having a toolbox of approaches, all of which are tested and true, and using your skills and experiences to know which one or ones to choose in a given situation. Evidence-informed practice isn't limited to manuals, rigid process, and off-the-shelf solutions, though there's a place for them too. It's about ensuring that services, from systemic planning to individual cases, are built on a solid foundation of evidence in all its forms. Harnessing the power of research evidence and integrating it into effective, evidence-informed practice requires a few things. A commitment from your organization's leadership to the value of evidence, along with a culture of professional development. Training and ongoing coaching, and your personal readiness and willingness to acquire new skills and to modify your practice. Here are 3 things you can do to move your practice toward a stronger EIP model. Gather evidence that is relevant to what you're doing and ask yourself why and how you should use it. Reflect. Begin the process of synthesis by bringing evidence together with what you know, what you live in your day-to-day practice. Reach out. Draw upon information and opinions from colleagues and, of course, from children, youth, and families. At the end of the day, using evidence in a systematic way will strengthen your practice, without having to deconstruct and reconstruct the way you think and work. It's about embracing clinical wisdom and client voice within a structure that brings it all together. It's about committing to learning and keeping your mind open to the fact that those tools in that toolbox will change or be updated from time to time, making them and you stronger and more relevant. And perhaps most importantly, living an evidence-informed practice is all about enhancing your ability to help children, youth, and families. The Center can help you.
So if we look at the importance of evidence-based practice as the video was talking about, first of all, we need to look at those empirical studies. What is the evidence telling us? But also bridging it to the experience that we have. What works and what doesn't work for our patients? What does our own organization have to say about it? And what do all the stakeholders, including the patients and their carers, have to talk to us about implementation of this evidence? However, there are circumstances where intuitive practice is considered as appropriate. For example, that is, you're a big expert, you know, about the evidence, although that doesn't really make it being intuition because you're still basing it on evidence. However, if there is a situation, which I think in wound care we don't have it, where there's insufficient scientific evidence, or we need to make a very, very rapid decisions, etc., you see there. But understanding that in our daily practice, that especially when we're thinking about wound care, we need to understand that there is evidence out there. If you look for best practice guidelines, if you look at all the recommendations which are out there from all over the world, if you try to research type of guidelines, you find a lot coming out, for example, from Australia. The CAWC is really great in doing this. And Wounds International website, there's loads of guidelines there. Again, I'm going to ask a quick question here that you answer between you and yourself. If you are dealing, for example, with patients with diabetic foot ulcers, are you aware of the IWGDF guidelines and recommendations? Have we looked at them, and do we base our practices on diabetic foot care according to these recommendations that are updated every 4 years? So this brings us to one of the first polls. I hope that I will manage to do this. Please question what? Hold on, I'm not the best when it comes to... Jonathan, did you launch the poll, or do you need me to launch the poll?
Yeah, I launched it.
Oh, you launched it. Okay, thank goodness for that. Okay, so what we are thinking about here, and it's already been alluded to in the video, and this is where we want you to think about: are patients' values important when we're thinking about evidence-based practice? You lead me with the polls, Jonathan, because I am not seeing it.
We have 12 out of 28 participated. We need a little bit more.
Yeah.
I'll leave it open for another 20 seconds. The true-false question.
We clicked the wrong answer.
It's no problem. Don't worry. This is not a test. Okay, so what's the score, Jonathan?
All right, let me end the poll and share.
Okay, so 94% plus the wrong answer, so we're probably around 98% are agreeing that that yes, patients' aspects are very, very important. This brings us to the if I may say, the creation of evidence-based practice in medicine that was started in Canada by this guy, Dr. David Sackett, who started talking about definitions, but even his colleagues later on continued in their hospital, and then it spread worldwide. About he used really important words: conscientious, explicit, judicious use of current best practice. Current best practice should be the basis, but as we'll see, sometimes we have to revert even to older practices to understand what is going on. So looking at integration of what we've already alluded to is, what are the empirical studies in alignment with our clinical expertise, thinking about the patient preferences and the patient needs. For example, one of the current best practices in diabetic foot care is application of types of oxygen to the diabetic foot. However, what many patients or clinicians or both don't realize is that most of this, for example, oxygen sprays is derived from porcine oxygen. So some patients who have their beliefs, which is not allowing porcine on their body, are we still using it? So that is why it's really, really important. Quick questions here. David Sackett actually practiced what he preached, and he did change practices according to evidence. So back in the early 90s, how long do you think that David Sackett, with a very, very old laptop, took to make a decision change? Taking 1 minute, 5 minutes, or about 10 minutes? Give you a few more seconds. I'm sorry if you hear some background noise. These are because I'm in the office here and my colleagues are still working. So, okay, I think we can stop it there. Yeah. So most of you think, almost half of you think that it's about 10 minutes. And yes, if you think about how long an old processor took. But actually, if you do look at what Dr. David did with that very, very old laptop, it actually took him about just a minute and a half sometimes to find answers. He was still using floppy disks. I think that most of you don't even know what floppy disks are. If you think that nowadays we have smartphones on us that has got all the information about the internet and we can find results in seconds, if we are in doubt, do we do like Dr. David Sackett and his team did and actually went and checked if their decision was good, and they actually changed about 1/3 of their decisions after looking at what the evidence is telling them? So if you look at different definitions, evidence-based practice, nowadays there's hundreds and hundreds of publications here telling us what to do, how to do it, how do we engage, and obviously it could be quite confusing. However, if you look at it, it's basically the same but little bit different with other definitions. And what was put in place by David Sackett and his team is still very, very relevant today. So if you look at what, for example, the Oxford Review tells us about it, it's again looking at the same things in different words, looking at that research, looking at how we are going to engage the experience that we have from experts, but also feedback from the practice, from the practitioners, more importantly for our own customers. So even if you search, and I spend hours searching to try to find different definitions, they're all basically filtered to the same thing, to the same definition that Dr. David Sackett and his colleagues talked to us about way back in the 80s and in the 90s. Sorry, I think there's something wrong with this video. It's okay, but let's skip that. So, the three main components. This is the building of evidence-based practice for us. So the first one is, what is the best external evidence? What is out there? What is published? What do we know which is scientifically sound research? Because it doesn't mean that it's published, it's scientifically sound. Looking at our expertise, drawing from our experiences, how we manage our patients, talking to our patients, talking to their carers, understanding what the care is. Previously, we used to talk about the three-legged stool of evidence-based practice, but now this has changed as well. This is one of the big changes that happened here. It all basically funnels down to the patients, and making the patients the core of our care is obviously nothing new to you, but understanding that even when we're looking at evidence-based practice, it's really, really important. And again, terminologies, multidisciplinary, interdisciplinary, and again, there's loads of documentation out there, sometimes quite confusing. But at the end of the day, it's all the same thing, looking at how that best practice can actually change our practices to improve it and to make sure that we start. But as we'll see, there's a methodology of doing it, starting with the inquiry, then looking at how we translate it into our daily practices. So the aim of evidence-based practice, why are we going to do it? First of all, we are knowing for sure now that we are providing the best quality of care. It can reduce healthcare costs drastically, and we have evidences from wound care, for example, of dressings that saves so much money for the patients, but also for the hospitals and the government. Empowers us with higher satisfaction because we know that we are providing practice that will, at the end, improve the patient outcomes. So in nursing, what is evidence-based? Is it different? It's basically the same thing, again, encapsulating it in different terminologies, but we talk a lot about the holistic and quality care. And remember, although this is generic, this also funnels down to wound care practice. Looking at not what we think will work, but looking at what we know 100% for sure will work. This doesn't come from intuition. This doesn't come from traditional methods or advice. This comes from that evidence that we know, understanding for sure 100% that what we are giving the patient is the best. So do you think, because we've been talking about evidence-based practice, started off with Dr. David Sackett. So did we only start in the 1980s, or did we start also in the 1800s talking about evidence-based practice? So we're talking about a couple of 100 years ago. This is just a trivia. I see people are opting for maybe that's the safest one, yeah? Okay, we'll give you just a few more seconds. Yeah, I think we can close it as well. So most of you are saying maybe, some of you are saying yes, and some of you are saying no. So the answer to that actually is yes, because even if you look back into what Florence Nightingale was telling us, she was already talking about the origins of bridging the theory to practice gap. So we've been talking for more than 200 years now about how shall we bridge the theory to practice gap. That is a really simple answer. Implementation of proper evidence-based care. Understanding that the treatment that we are giving is the treatment which is based on evidence, not based on what we think will work. So if you do a research, you will find hundreds of answers out there. And this is just a synopsis of what we think. But definitely what is the most important thing is a simple solution. It's providing care that we know is the best, not what we think is the best. Option-based decision, why do they still happen? Because unfortunately, some people do resist evidence-based practice. Some people just will give you their judgment without having that basis of evidence. And although it's not totally with evidence-based practice, I think reflective practice is really, really important to marry with evidence-based practice where you reflect on your actions. And again, there's a lot of literature out there. If you're interested in it, I suggest that you look at the dimensions of reflective practice.
As healthcare professionals, We have a responsibility to care for ourselves as well as our patients. But how can we ensure that we are doing this in the best way possible? We can do this through reflective practice, which is a way of thinking deeply and honestly about any aspect of our professional practice. It's about creating space to reflect on our work and the experiences we have had. It's a way to learn from our successes and mistakes to grow and become even better healthcare professionals. Reflective practice is not just about looking back on our actions. It's about engaging with the relational aspects of our interaction with each other. It enables us to unpack the emotions that surface by creating a space to share and learn about each other and truly share our human experiences. This includes acknowledging what we have done well and creating opportunities to learn from each other. Reflective practice can take place in a group setting like this one, but it can also be done individually. It's all about finding what works best for you. Reflective practice is an essential skill for all healthcare professionals, not just clinicians, to develop and integrate into their professional practice. It's a crucial aspect of ensuring safety and quality in the healthcare system. So, why is reflective practice so important? Engaging in regular reflective practices has numerous benefits for both individual healthcare practitioners and the broader health system. It improves self-awareness and the ability to manage emotions, including our reactions to situations and a greater understanding of our personal triggers. It fosters higher levels of well-being by contributing to reducing levels of stress, emotional exhaustion, and burnout. It strengthens the ability to adapt and respond to situations through the growth and exploration of insights. It supports higher levels of job satisfaction, enriches on-the-job learning and skill development, strengthens patient safety and care, and ultimately contributes to reduced staff turnover. These advantages can also help with staff recruitment and retention. We all have an opportunity to develop and integrate reflective practice into our daily routine, no matter our role. By embracing this process, we can create a space to learn, grow, and become the best versions of ourselves.
So, as we said, it's not an integral part, but it is very important to understand it. Now we start looking at the different terminologies. If you look at the evidences out there, we're not going to go in all the terminologies. We don't need to go, but it's very important to understand that when you are looking at evidence, understanding the basics of critiquing an article, and we will look about understanding how to do that in a few minutes. So again, looking at exploring about what we need, preparing ourselves for the change, because remember that one of the hardest part is convincing people to change practice. But after once we implement, it's very important to continue to review to make sure that what we have implemented is still being carried out. And understanding about what we are looking at is very, very important, because unfortunately, if we look at change in practices due to evidence, sometimes we change our practices based on evidence, which is not really good. And one of the examples is change of practice of applying a kind of a dressing to reduce pressure injuries, which was basically implemented because of a study that was published. But when you look at the robustness of that study, it's really not a very good study, but still, because of the marketing power of some companies, we did change our practices. So make sure that we integrate evidence into our practice, making sure that we are removing all our old wives' tales, removing all our historical things that we have been doing, but only making sure that we make sense of the evidence and acting on that evidence. So it brings us to the close of the first part. If you have any questions, we'll be very happy to answer now, but we will also have another 5 minutes or so at the end of the session. Any questions? Doesn't seem so. So I suggest that we take a quick 5-minute break to do whatever you need to do, and we'll meet again in approximately 5 minutes. Yeah, thank you. Okay, I think we can continue the session. Hope that everybody is back. So continuing on what we were talking, and we'll start again with another poll question here. The question is Pico. What is Pico? Is it a type of dressing? It is a cleansing product, or do you think it's a way how to incorporate evidence-based practice? Well, if you think about what we're doing today, probably you will know the answer, yeah? Give you a few more seconds. Okay, I think we can stop that. Well, this was a bit of a trick question. Yes, Pico is a type of a dressing, But if we're looking about what we're talking today, we are not talking about the dressing, but we are talking about a way how to formulate a question, which is the PICO methodology, which is very interesting because the PICO terminology is usually used for the formulating of a hypothesis for a meta-analysis or for a systematic review, but it can help us in everyday practices. And what is very important is that if we do challenge ourselves, which we should be challenging ourselves, think about what type of patients, what type of population or problem do we have? What is the intervention that we are doing nowadays, what type of dressing we are using, and then compare it maybe to a dressing where we have seen the evidence, implementing it, and then check the outcome to see if the implementation of the practices that we have changed did actually give us benefit.
After you've chosen a general topic to research, the next step is to refine the topic into a clear, answerable question. The PICO model walks you through the process of defining clinical questions. The 4 parts of PICO are patient problem population, intervention, comparison, and outcome. P might stand for patients of a certain age or sex, populations who may live in a geographic location, or those with a similar primary problem. I stands for intervention, and this can include therapies, diagnostic tests, or preventative measures. C is for comparison or control. Are you comparing one intervention to another? Finally, O stands for your desired outcome. Let's take a look at the general topic of pediatric diabetes. Searching PubMed for these terms brings up thousands of results on a variety of topics that range from the rates of comorbidities to drug therapies and social determinants of health for children with diabetes. Our goal is to create a focus question that only looks at one of these topics. Consider this question: what is the efficacy of metformin versus rosiglitazone on glycemic control for children with type 2 diabetes? In this more focused question, our patient population is children with type 2 diabetes. The intervention is metformin, and this is compared to rosiglitazone, and the outcome is glycemic control. With our focused question and the parts of PICO defined, we now have a list of terms that we can use to start searching the literature.
So as we said, we are quite lucky because once we have formulated the question, we will find that people have already done this, and this is where we find those guidelines and best practice recommendations there that we talked about previously. But the application of PICO in our daily practices is challenging what we are doing, understanding what we are doing is actually based on the best evidence which is out there. So where do we find the resources and how do we understand what we are looking at? So here, quick question, again, another trivia question. What do you think is the highest level of evidence? Is it a meta-analysis, an RCT, or an expert opinion? Just a few more seconds. Okay, as we see, most of you have answered according to the hierarchy of evidence, where we see that at the top of the pyramid, we will always find meta-analysis and systematic reviews. And this has been out there for many years, talking to us about if you want to look at the best evidences, always you have to look at the top of the pyramid. But nowadays, actually, this is being challenged because if you think about your practice, You don't randomize your patients, and you don't control your patients, and you don't do a systematic analysis of what is happening, but rather what we do is we look at real life evidence. And this is why nowadays we're looking at the type of what is being talked about, the naturalistic methodology, looking at very robust observational studies, but also case series and reports. So yes, we still need the meta-analysis and RCTs, but then it's very, very important that observational studies and case reports are published to substantiate those results that were done in an MA or an RCT into our daily living practice, because then, only then, we will know that what we are doing will be efficient and practicable in our own clinics rather than just in the empirical studies. So as we said, the benefits are very, very important because we know that we are targeting effective treatments, we are improving the quality of life for our patients, we are posing them less risks, and the financial benefits are very, very important. So if we look at evidence, one of the biggest things that we always talk about is a moist wound healing environment. So when do you think we actually started talking about this? In the 1890s, 1940s, 1960s, or just a few years ago? Again, another trivia question. Okay, just a few more seconds. Okay, thank you guys. So 4 of you actually got it right. And this is where we see that the evidence talking about the moist wound healing actually started in the 1960s by, he's considered now as the grandfather of moist wound healing, which is George Winter, where he did a study on some animals, and it showed that if you dress the wound, if you cover the wound, that moist wound healing environment will help it more. And we'll look about this when we're talking about the wound bed preparation. But this is where I alluded to previously that even if it's not current best practice, if it is still relevant currently, then we need to think about it, because obviously we still believe that moist wound healing environment is really good. This is just one example of how evidence-based practice changes the way we work, changes the way we practice. Unfortunately, it took us about 20 years to understand it, or well, basically the industry realized that there's a lot of money to be made out of this study, and this is where they started creating all the interactive dressings that we know about today. So looking at quickly going through the different definitions, if we look at what a meta-analysis is, it's examination of a large number of data which is already published using specific statistical techniques to concentrate on what is the results of these best outcomes. What we look at a lot when we're looking at best practice recommendations is systematic reviews, where somebody does a PICO analysis or a PICO hypothesis, and then does a systematic search to define what are the best answers to that question. And this is where we can consider ourselves quite lucky in wound care, because there's a lot of systematic reviews out there that will synthesize and summarize the results for us already. RCTs, randomized controlled trials, are very, very important as well, because this is where we even look at comparison between one dressing and another. And basically an RCT is you have 2 cohorts, one is exposed to one treatment, one is exposed to another, understanding about what it happens. One thing to remember also about RCT is blinding. So blinding basically means that if it's a single blind RCT, it's the researcher knows which participant is getting the treatment. Double blind, neither of them? No. This is important to reduce bias. So basically what we are saying, even when it comes to wound care, is that the highest level of evidence is is definitely a double-blind study, which is not very common in wound care. It's usually an open-label trial because dressings look differently, but there are very few double-blind studies in wound care which has actually changed practice, especially when it comes to the management of venous leg ulcers and diabetic foot ulcers. Observational studies, as we alluded before, are very, very important. This is where we have a group of patients, the study population, which are exposed to treatment. Nothing changes from what they do every day, but what they look at is understanding the results of the change in practice. This can be retrospective or prospective. Basically, are we looking at the outcomes as they happen, or are we looking at the outcomes which are historical? Case reports, it's something that we have to take sometimes with a pinch of salt and understanding why these case studies are being published. Is it basically just somebody trying to do marketing, or is it a clinician that has looked at, for example, a randomized control trial that has been done in Europe, then replicating those in his own or her own cases in their own country of origin? And it's very important also for case reports because it shares practices between clinicians. And when a case study is published with the intention of sharing these best practices, it is a very good way how to look at it, because one of the things that case reports do include are the pictures, and obviously you can see how it changes the care of those patients. When it comes to expert opinion or anecdotal opinion, again, we have to be very, very careful what we are looking at. Why are these people saying what they are saying? For example, we're talking about an expert opinion. Why is this person telling us that ABC dressing is better than XYZ dressing? What are the biases? What are the intentions? It's really, really important. But there are nowadays, obviously, if you look on social media, places like LinkedIn and different types of blogs, there's quite a few expert clinicians that share their practices, which are really, really, really good. I can give you an example of a couple of them. For example, David Armstrong, that posts a lot on LinkedIn. Then we have from Spain, we have clinicians that have a website that gives us all the latest evidence. They give us their opinion. Maria Conda is the leader of that, and talking about why they think that this best practice should be implemented for ourselves. So, do we need to understand everything? In a nutshell, we don't need to go in depth, but understanding what these type of studies are and why they are important. However, remember that when it comes to our daily practices, looking for best practice guidelines and systematic reviews is probably the best shortcut that we can take, because the people that are behind these systematic reviews and guidelines have already done the work for us.
Understanding clinical trials. Clinical trials are research studies that evaluate new ways to improve treatments and quality of life for people with diseases like pancreatic cancer. Clinical trials are an option for all patients to consider and play an important role in improving healthcare. Results from clinical trials help develop new drugs, new diagnostic tools, and new clinical procedures. Clinical trials can also spur new questions for research, which lead to new discoveries over time and help us to better understand diseases like pancreatic cancer. All the drugs and tools we have today were made possible because patients volunteered for clinical trials. Every clinical trial has what are called eligibility criteria. For example, a patient may need to have a certain medical condition or gender or other specifics to meet the criteria of participating in the clinical trial. Otherwise, they are not eligible to join that clinical trial and could seek another trial that better fits their situation. Patients who want to volunteer need to understand the potential benefits and risks of participation in a clinical trial. Patients may personally benefit from receiving new therapies or procedures. They receive close supervision from clinical staff. Sometimes the cost of the new drugs or testing is free or waived. Participants may also be part of a research breakthrough that helps thousands of future patients. Patients face the risk that they may not benefit from the new treatment. Additionally, participating in a clinical trial requires commitment. Trials can be lengthy or demanding and may require extra treatments, extra time in the clinic, or tests or costs that are not part of standard care. It is possible, if the study is randomized, that they may be part of the control group that does not receive the new drug being studied. Informed consent is a process that helps patients make an informed decision about whether to join a clinical trial. An informed consent document will be provided that explains the purpose, procedures, and potential benefits and risks of the trial. There will also be thorough discussions between the doctor and patient so that all questions can be clearly answered. In late-stage clinical trials, participants are generally split into two groups at the beginning of the study. One group receives the standard treatment plus the new treatment. This group is called the treatment group. The other group receives the standard treatment only and does not receive the new treatment. This group is known as the control group. A computer is used to randomly assign the patient to either the treatment group or the control group. Randomization helps to prevent bias because neither the patient nor the doctor can choose which treatment group a patient is assigned to. Some clinical trials may want to study the effectiveness of adding a new treatment to a standard treatment to see what works better. In these studies, half the patients will receive the standard treatment plus the new treatment, and the other half will receive the standard treatment plus a placebo. A placebo is a treatment that looks identical to the new treatment, but contains no active ingredient. These types of studies are often called blinded, meaning that one or more parties involved in the trial do not know which patients have been assigned to which treatment. Single-blinded means that only one party, either the researchers or the patients, knows which patients have been assigned to which treatment. Double-blinded means that both the researchers and the patients do not know which patients have been assigned to which treatment. The strongest, most reliable results come from clinical trials in which the treatment is double-blinded, the patients are randomized, and the study has a control group. This is called a double-blinded, randomized, controlled clinical trial. Clinical trials are carefully monitored to protect patients, and several layers of review committees are involved to protect patients from any possible harm. Patients can leave a clinical trial at any stage. However, they should discuss this with their doctor before exiting to ensure the safest procedures are followed. There are 4 different phases of clinical trials. Safety is emphasized in each phase. If a trial does not have a positive or safe outcome in Phase 1, then it will not be allowed to proceed to a Phase 2 trial, and so on. Before a Phase 1 trial begins, there is a Phase 0, where the new treatment has already been found to be safe in animals or healthy human volunteers. In Phase 1 clinical trials, a new treatment is tested in a small group of participants for the first time to determine a safe dose and see how the treatment affects the body. Phase 2 is conducted with a larger patient group than the previous phase and studies how well a new treatment or combination of treatments works for a certain type of cancer, like pancreatic cancer. At this stage, the eligibility criteria become more restrictive. Phase 2 studies can be either randomized or non-randomized. Phase 3 trials are conducted in an even larger group of participants. This phase involves a randomized design comparing the new treatment to the standard treatment. If a Phase 3 clinical trial is positive, typically the new treatment will be approved and licensed for use in the United States by the Food and Drug Administration, or FDA. After the treatment has been approved, Phase 4 clinical trials involve monitoring to continue to assess safety, effectiveness, and optimal use.
So if we did, obviously in pharmacology, these type of studies are more stringent, but also when it comes to very well designed clinical trials for wound care, it is still the same. So these are some of the examples of the databases that you can search for evidence. The most popular is PubMed because it has open access. Not all the journal articles that you find in there are free, but at least it allows you to make a search and also allows you to save that search. Medline and Elsevier are quite good, but there are also other databases that you can look at. For example, CINAHL is very, very important for nursing and the allied health literature. Even Google Scholar, not the normal Google, but Google Scholar gives you a good subset of peer-reviewed journal articles, but also books, etc. Another interesting database, if you've never went into it, which I suggest that you do, is the Cochrane Library, which is named after Professor Archie Cochrane from Scotland. And the nice thing about the Cochrane, it's a database of different types of reviews, trials, etc. Again, it is free access and you can get into it very easily.
Let's start out with the following clinical question. Do women who drink soda have an increased risk of heart disease? If I try to treat PubMed like Google, and I copy and paste this sentence into the search box, I won't find any evidence to answer this question. Instead, I need to craft a search that a database like PubMed will know how to interpret. The first step to crafting a database search is to figure out which words to put into the database. The PICO model can help us with that. When we put this clinical question into the PICO format, it looks something like this. Our patient population is women, the intervention or exposure is soda consumption, and we compare that to those who don't drink soda, and the outcome is increased risk of heart disease. From here, I need to determine the main concepts that need to be included in my search in order to answer our question. The concepts that are crucial to answering this question are women, soda, and heart disease. The next step is to figure out if there are other ways to describe these concepts, since not all authors may use the same terminology. For instance, a related term for women is female. Other ways of describing soda are sweetened beverages or soft drinks. A related term for heart disease is cardiovascular disease. Finding the right words to use takes some time, and you may find additional keywords to add to your search after you've done some looking around. Notice the ors between the related words. Or is a Boolean operator. Boolean operators are used by databases to define the relationship between terms. And is another Boolean operator. Adding an or between two words asks the database to find either term in the article record, and asks the database to find both terms in the article record. Use or between synonyms or related words, and use and to combine together the main parts of your search. Let's review our list of topics and keywords. We determined the main topics that need to be included in our search results, and we found alternate ways of describing the topics. When we go into a database like PubMed, we can use the Advanced Search Builder to craft our search. It's easy to copy and paste the topics into separate lines. When you use Advanced Search, PubMed adds parentheses around the related terms to keep everything in order. Use ands to connect together the separate topics. Because this search is formatted into something that PubMed can more easily interpret, there are many more article results.
So another thing that we need to look at is, if we're looking at randomized control trials, is the p-value, because the p-value is very important because it tells us if the results that were achieved were actually because of that intervention. The p-value needs to be to equal to or less than 0.05, which means there's a 5% probability or less that the outcome is due to chance. The next step is to understand what we are looking at, and this is done by means of appraisal. And a very, very easy way how to appraise an article to understand if it's good or not is a program called the Critical Appraisal Skills Program, or CASP. We have the link there to the webpage, which brings you to a list of different type of tools. These can be downloaded in Word or PDF, and you answer the questions. For example, for an RCT, it's 11 questions, and will tell you if that trial that you are looking at is reliable or not. There are obviously other type of tools that can be used. For example, here we have the Prisma, which is the way of reporting systematic reviews and meta-analysis. So if we're looking at a nutshell about wound care, what do we need to look at? What do we need to make sure that the randomized controlled trial or whatever we're looking at is telling us? We need to look at three important things that we will look at together. So the first one is clinical efficiency. If that dressing, for example, claims that it reduces healing time, does it really reduce healing time? If it's a dressing to reduce infection, is it really reducing infection? And we find these from all the types of evidences which are out there, not just the randomized control trials, but obviously those observational studies will help us quite a lot as well. The second one is looking if the studies or the ad hoc analysis of these studies actually looked in the health-related quality of life. That is, how did the dressing affect the outcomes for our patients and their psychosocial well-being? Many of these studies do not talk about this, so my suggestion is to look out for those dressings that had publications, many times post-hoc analysis of randomized control trials that talk directly about health-related quality of life. Now, we're going to talk about money. So, very important question here for you guys. Do you think that the price of a dressing is very important and that we need to do it in our economic benefit analysis when we are choosing the type of dressing? So, do you think it's true or do you think that's false? Waiting for the poll, Jonathan. Give you a few more seconds to think about it. Okay, we can end the poll here. So what I'm going to say is congratulations to the one person that said it is false, because when we are looking at the expenses of a dressing, the dressing only makes up a maximum of 20% of the whole cost. If you're looking at cost-benefit analysis, is the dressing that I'm using beneficial in saving money? You have to think about the treatment cost, not about the dressing cost. If you look at what is happening, you need to look at the direct costs and the indirect costs. So there have been also studies that have shown that when you use these more, well, the price of the dressing is more expensive, so many times the cost of the treatment is reduced. So what is very, very important for you is not to ask the price of the dressing, ask the price of the treatment from the first day that you meet the patient until the time that that wound has been healed. If you look at cost-benefit analysis, for example, the introduction of a perceived expensive dressing in the management of diabetic foot care in the UK, it was suggested that if 25% of patients are treated with this type of dressing, which is a sucrose octosulfate dressing, then the NHS would save £5.4 million per year. So don't ask the price of the dressing, ask about the price of the treatment. That new treatment needs to be better, but obviously be less expensive. And less expensive is not the price tag of the dressing, but the price tag of the whole treatment. The next big step is change of practice, which is probably one of the hardest things, because to manage to convince people about changing their practice is quite difficult. So we need to check, first of all, is the results that we have seen, are they applicable to our patients? Do they fit in the values for our patients? And once we see that, we implement it, but we don't stop there. What were the outcomes of this practice changes? And my suggestion is, if you're doing a bit practice change, please do document them, because then you can publish the results and gives you even better satisfaction that you can share with the rest of the wound care community about your best practice experiences. So one of the very interesting models of the bridging of the gap between practice and knowledge is the ACE STAR model. It has been around for quite a few years, but again, it is still very, very applicable. Talking about what we already discussed is, if we have a question about our type of management, what is the research behind it? What is the summaries that we're looking at? How can that be translated in our daily policies? Integrating it into practice and making sure that we are evaluating the endpoints as it happens. So in a nutshell, select the best practices out there. My suggestion is go into websites, like I said, like the Canadian Association has a lot of best practice guidelines. And even if you look at the webpage from Wounds International, they have quite a few best practice recommendation. Make a systematic decision making in your practices, how we need to change, who's going to happen. I suggest, if you're going to change practices, look also at the change practice management ideologies which are out there and theories which will help you do that. And then make sure that once we have adopted, everybody is still adopting it and we are seeing the results that we need. So these are some of the instances, as I said before, about practices that has changed because of evidence. We've talked already about the evidence by Dr. George Winter in 1963 that showed that a moist environment leads to better outcomes. We had multidisciplinary teams in implementation of wound care, and we saw evidence how that improved wound care. We looked at, for example, if we look at venous leg ulcers, we look at different comparisons of different types of compressions. Multi-layer compression bandages have been shown that they would provide us with the best. And again, the double-blind study I referred to you before with the sucrose octosulfate dressing, that has changed totally with the way we look at the management of chronic wounds, especially venous leg ulcers and neuroischemic diabetic foot ulcers. So practice can be changed and should be changed. So if we're saying that evidence-based practice should be the cornerstone, do you think that there are still patients who do not receive care according to evidence? Do you think that would be 10, 40, or 80%? Jonathan? Okay, we'll give you just a few more seconds. Okay, so most of you actually did get it right, because if you look at a paper that was published, it suggests that about 30 to 40% of patients do not receive evidence-based care, and actually about 1/4 of our patients receive care, which is either not needed or can be potentially harmful. And this is also when it comes to wound care. We are still using dressings, which unfortunately, we know that they are not correct. For example, using these type of greasy gauzes, these type of tool dressings which have got paraffin or Vaseline on it. If we go back to George Winter, for example, he published a paper in 1975 suggesting the dangers of applying these types of dressings. But unfortunately, even though we know that they can be harmful for our patients, we still are unfortunately using it in our daily practices. So these best practice guidelines are out there for you. If you need some of the links for these best practice guidelines, please do let me know and I can share them with you. So obviously the benefits for us is that we have basically policies already written for us, gives us that consistency of care, making sure that what we are giving is the best solution. Obvious benefits for the patient is that they are getting the best care, they are getting less complications, their wounds are healing faster. And for the healthcare system, obviously that best practices will be optimizing the value for the money that is being invested. So again, if you want to think about guidelines, there's actually a guideline on how to implement the guideline. This comes from the Association of the Royal Nursing Colleges, which helps us to implement these best practice guidelines in our daily practices. Make sure that it is a good practice. Look at who has funded the practice and make sure that these best practice guidelines, although they are funded, can be of good value, but making sure that what we are implementing is best evidence out there. So in a nutshell, as we said, for you guys, if you do evidence-based practice, you know that you are treating your patients in the best possible way. The patients don't know we are treating them the best possible way, but what they do know is that their wounds are getting better and their life is getting better. And obviously for the healthcare economy, if we implement best practices, it will enhance not just the satisfaction, but it will also enhance cost savings. So that was the end of the session today. If you have any questions, please do let us know, and we can answer them now. We can even send us questions later on. You can send us emails. We'll be more than happy. But please feel free to share if you have any queries or even any comments. Seems that we are clear.
Emilio, I have colleagues who have questions for you.
Sure.
Hi, Mr. Emilio. Good evening. Thank you so much for your first module. It's very nice and interesting. Just to add on one question, which is really now happening in our clinical ground. Since we are hearing about all the research papers, all these things, how to explore all these guidelines, now I want to find out about the PP wash, potassium permanganate wash for the IAD. So how was your... Yeah, because I do hear when we find some research, not much interesting. The last we can find out is only on 2021. So what's your opinion in this for IAD using a PP wash?
Basically, if you're cleansing a wound, there is only one very simple question to ask: is it cytotoxic or not? And if you look at the evidence of acetic acid, if you look at evidence of potassium permanganate and povidone iodines, etc., is that it is usually cytotoxic. But the best practice means that you have to look at the evidence. If you're looking at just one article that suggests that the use of potassium permanganate is good, challenge that article, appraise it. Is it talking about a systematic research that was done about randomized control trials, meta-analysis that actually did show that this modality is good or not? I doubt it, because we know that these type of washes are harmful. My suggestion is, if you're in doubt, forget it. What we do know that there are a lot of cleansing solutions which are safe, which gives us good results. Hydrochloric acid, for example, and all these type of new cleansing solutions which are coming out there. Again, don't look at marketing, don't look at brochures, look at the evidence, because obviously all the companies will tell you that theirs is the best. When a rep comes to you, challenge them. The only thing I can tell you, if you challenge the Urgo Medical reps, they will be very happy because of all the evidences that we have. So evidence-based practice. If you have any doubt, forget it.
All right, great. Thank you so much.
You're welcome.
Appreciate it.
Any other questions or comments? So I think that's a wrap up for our first module. We've got quite a few to do. Again, if you have any questions or comments, please do let us know. I think